Thank you, Cheryl, and really it's been a pleasure. I was here last year and I got to meet a lot of great patients and families. And yesterday I got a chance to meet about 6 or 7 families. What I learned last year was that the families really were so much more educated about the topic than I had anticipated for. I put together a nice little topic about the jaws and the teeth, and then they'll come and say, well, you know, there's this guy over here, and he's got literature on progressive dysplasia, and I realized, well, you know, really the families are researching this, they're looking online, and they're coming with really sophisticated questions. And so I upped the talk a little bit. And so, and who knows, if it's a little too technical, you know, we can always dial it down a little, but I'd rather put the information out there. I think I have a half an hour. And really, you know, I want to make it as simple for you, but still give you the important information. And to segue before I get started about the anesthesia, you know, my experience at Children's Hospital and then at St. John's is that most of these children, your kids that we're operating on that have hemifacial microsomia or isolated microtia really don't have many other comorbidities with the heart, lungs, the liver. And the anesthetic risk, I have found in that experience, in my experience, has been very low on that. Now, a lot of children I operate on, and maybe a lot of stories you might see on the internet, those children are at a much higher risk. And if they have really multiple comorbidities, of course the anesthetic risk goes higher. But in general, when we're talking about microtia, hemifacial microsomia, Pierre-Robin, isolated craniofacial anomalies, my experience has been that it's very, very small. As a matter of fact, it's so small. I mean, I operate on children from 1 day of life till 18, 19, 20, that I have actually pushed our hospital, and we've gotten IRB approval to do cleft lip repairs, which cleft lip repairs, children that are born with cleft lip, traditionally we wait till 3 months of age, but now we're going to do it at 1 week of age because the studies on neurotoxicity and really haven't been conclusive. So I'm operating on children at 1 age for non-elective, 1 day, and for elective, a week to 10 days. So most of your children that undergo an ear or a jaw operation are well into their adolescence. So with that being said, interestingly, yesterday someone told me, you're the jaw guy, or you're the jaw doctor. And I said, when I was younger, I never thought I'd be the jaw guy, but I don't think Cheryl ever thought she'd be the ear person, and Dr. Kessler, the other ear person. But at the end of the day, it's great because we have our own little subspecialties. But in reality, if you ask 5 different plastic surgeons and 5 different oral surgeons, and those are the 2 specialties that you're going to run into on the internet and you're going to run into with your consults. You're going to get plastics, oral surgery. Oral surgery is a specialty of dentistry, plastics a specialty of medicine, and you're going to get 5 different answers. You're going to get 10 different answers. And there's this black box that people really run into, and they get a little bit confused. And what I'm going to try to do is just make it very simple for you. You already know that there's a microtia and there's an ear, and we need to fix it. Whether it's fixed at 4 or 6 years of age with MedPOR or autologous rib reconstruction, the issues on the jaw remain the same. And we look at the upper jaw, the maxilla, the lower jaw, the mandible, and the teeth. And all of those really go hand in hand when you look at microtia repair. What we want to do is, you want to know, should I get the ear fixed first or should I get the jaw fixed first? In general, I would tell you 85% to 90% you're going to be taking care of the microtia, because what we look at is the severity. In severe cases, in severe hemifacial microsomia, in severe craniofacial microsomia, Treacher-Collins syndrome, and I'll go over those 3 major entities, those severe cases, then we consider a process called distraction osteogenesis. Last year I said, oh, we consider a process of stretching the jaw, and a family asked me, goes, well, distraction was really discovered by Lizaroff, and I said, okay, I get it. Yes, it's distraction osteogenesis. That's an operation, and we'll look at some pictures of that operation. So either you're going to be in a severe case, you're here, and I tell you, well, the jaw problem is severe enough that we should consider doing something before the MedPOR or the ear reconstruction, or you're going to fall into the remaining 85, 90% where you're going to get your ear reconstructed first, and then we follow the jaws as you continue to get older. Now that's the good news, is that 85, 90, 95% you can get the ear done first. On the flip side, most of those patients will require a pediatric dentist, an orthodontist, They will require correction of the teeth, and then in their teenage years, correction of the jaw to correct the bite, essentially. And that decision is based on what we call the cant and the severity, but it's also based on the completion of growth. Kids go through a growth spurt in their early years, and then when they're 15, 16, they're going to hit another growth spurt. So will they need a jaw operation? Possibly, even probably, but for sure they're going to need, I can tell you, they're going to need what I had mentioned, the restorative dental work, dental extractions. If the jaw is small, you're going to need the wisdom teeth extracted, and you can almost count on it, start saving. You're going to need an orthodontist, and you're going to end up, having to get braces. But really, that's not much different than most other children. The real question becomes is surgery. What do we need for surgery? Do we need it now? Do we need it later? The images that we like, or the preoperative evaluations that we like, are some basic dental x-rays, bite wings, which is when you go see your pediatric dentist. Those help, but they're not the greatest. I like the dental cone beam CT because the Panorex is, if you go to your dentist, it's a machine that spins around. It gives you the same amount of radiation as this dental cone beam CT. So if your child has microtia and they're going to get a CT to look at the inner ear, that's a great time to just ask them to get the whole head, the upper jaw, lower jaw, the whole deal. If they're not getting a CT to look at the inner ear, at about 4 to 6 years of age, it'd be nice to get that dental cone beam CT. And the reason we want to get that is we want to look at the severity, we want to consider the age of the microtia repair, and then stratify when are we going to fix the jaw and look at the bite. So if you need an operation, really the operations are broken up into what I had mentioned, which was if it's severe, that's the childhood distraction. In your teenage years, you may need a SARPE, which is a surgically assisted rapid palatal expansion, wisdom teeth extraction, which I had mentioned, orthognathic surgery, which is jaw surgery. Lefort 1, BSSO. The Lefort is named after Dr. Lefort. That's the upper jaw surgery. BSSO is the lower jaw. And the genioplasty is the chin. And what we'll do in a few minutes is we'll look at some cases on the extreme side, and then you'll really get a good understanding of where to go with that. Okay, so your child has microtia. Most of the children here, if they have microtia, a lot of the issues the families tell me is that, well, I can tell that the chin is off a little bit. And my doctor noticed the chin is off. And that is a reflection of the mandible. It really isn't the chin. The chin is off because the jaw is small on one side and it's growing. But we don't actually correct the chin. We correct the jaw. I already showed you this. These are the type of operations. I get a lot of questions before I get into the cases is, will the insurance cover the jaw surgery? And in general, yes, most insurances cover the hospital. Most insurance plans cover the upper jaw, lower jaw, and the teeth, the wisdom teeth, you got to use dental insurance. Most medical insurances will cover those operations as long as they're part of microtia, syndrome, a craniofacial anomaly. All right, so now we'll go into, I think I have a half an hour, we've only done 5 or 6 minutes. Now we'll get into the terminology to help educate you and really, as you see outside practitioners, to give you an idea of the basic terminology that oral maxillofacial surgeons will use as well as plastic surgeons, and then we'll bring it together in case presentations. So the maxilla, we already mentioned, is the upper jaw. The mandible, the important thing to remember at the mandible and in microtia is the entire jaw is split up into multiple pieces, but the important part in microtia is something called the condyle. The condyle is the joint. When you hear people talk about they have temporomandibular joint problems, that's the functional aspect of the joint. And we'll look at the CAT scan, we'll look at some CAT scans and I'll show it to you. The reason that is important is in microtia, the condyle is small. So that's an important term if your child has microtia is what's the size of the condyle, what classification is that condyle? Because the condyle dictates growth. When the jaw grows, it's growing because the condyle is the center of growth. When your child has microtia, if your child has right-sided microtia and the right ear is small or not present and the condyle is small, well, the left side is normal and it grows normal, and as it grows on the left side, guess what happens to the chin? It goes to the right side. So the other important term, oops, I skipped through that, is it's not working very well. is occlusion. And you'll see that on the internet, your dentist will talk to you. Occlusion is how the teeth come together, the upper teeth and the lower teeth. And we'll look at examples of that. And then a very important term for every family that has a child with microtia is this classification called omens. Omens gives you an idea of the severity of the jaw deformity, of the craniofacial anomaly. The O in omen stands for the actual orbital discrepancy. So we look at the head from the top all the way to the bottom. We look at the eye and we say, is the eye, the orbit, is that normal? If it is, they get a number, and if it's abnormal, they get a number. And it's 0 through 3, 0 being normal, 3 being severely abnormal. Then we look at the M, which is the mandible. And then we classify it. And since this is a jaw talk, the M is given a number 0 through 3. It's given 0, 1, there's actually 2A and 2B, and then 3. So that's the critical portion of when you start trying to make a decision. Do we get the jaw done first, or is it the ear? It's based on this omens classification and the jaw deformity and the severity of that jaw deformity. We all know what the E is, that's ear. N is the nerve. Some of your children may have weakness in the nerve that helps with smiling, and that's given a severity. And S is soft tissue. So if you Google it, if you look at websites, you'll see the better sites that you find will always mention the omens classification. And I already mentioned we're going to talk about distraction and orthognathic surgery. So in an adult, we look at facial analysis. In a child, we do the same thing. We split up the face into thirds. We split it up in the vertical as well as the horizontal plane, and we look for symmetry. No one is 100% symmetric. You can be, the world's most beautiful model. If you separate it, everyone has asymmetries, and that's beauty in of itself. So just because your child has some asymmetries doesn't necessarily mean they need an operation. But what we're really looking for is the asymmetries down in here, not so much up in this area. And in order to encompass that, we look at the bite. And these terms, when I showed them last year, everyone said, "Oh yeah, we know overjet and overbite," but I'll go over it, as simply as I possibly could. Overjet is when you see your pediatric dentist or your regular dentist, and they talk about you have a deep bite or an underbite. What they're talking about is overjet and an overbite. Overjet, I think of jet as a jet that goes this way and takes off. That's the distance or dimension of the bite in the anterior-posterior dimension. In other words, from here to here. As the bite goes this way or backwards, that's considered the overjet. And then, like I said, I'm a pretty simple guy. A jet flies this way, and this is overjet. Overbite is the up and down relationship. So you can have a deep bite. What most people use is I have a deep bite. That's the overbite. Or they could have a recessed jaw, an underbite, and that's this way, what we talk about the overjet. You could have a lot more complicated orthodontic issues like crossbite. In other words, these teeth over here, which should be out here, are on the lingual aspect or by the tongue. And all that in this patient ends up getting corrected in the teenage years. In children, with deciduous dentition or the baby teeth, there's really nothing to do with those anomalies. And we talk about, the reason I show this is really what I want to talk about is this one right here. So we look at the jaws in the anterior-posterior dimension, and then we look at it in this horizontal dimension. This is a normal relationship right here. This is what I'd say is a normal cant, C-A-N-T. A cant is the angulation of the upper and lower jaw. And the reason this becomes important is that in hemifacial microsomia, craniofacial anomalies, if this cant, this curvature, is significantly deviated to the right or to the left, that may be an indication that your child would need an operation before the ear surgery, or if it's significantly deviated in the teenage years, you would need an operation as an orthognathic surgery in terms of a Lefort BSSO. So we're going to move it. So this is normal, abnormal in terms of the cant. So when I see a patient and they look like this, I tell them, don't worry, get your ear done, you're going to be fine. Once they get past about this angulation and the upper jaw and lower jaw are at that much of an angle, then we say, well, do you need distraction before your jaw surgery? Or can we live with this and then deal with it in the teenage years? This just shows when we make the analysis of the jaw, we actually do it now by 3D CT, but traditionally what we do is we take measurements based on the skull base, a cephalometric analysis. The only reason I show this is because a lot of times I'll ask you, can you ask the orthodontist to get me a cephalogram? A cephalogram is, relates to the upper and lower jaw. It's a plain radiograph, and then that way we can take measurements. This is a child who waited and waited and waited. And the reason I show this is because if I would have seen this child when he was a 4 or 5-year-old child before any ear work, I would have said, well, let's do a distraction osteogenesis. So I show this because if you let it go and you don't address, and it's a severe case, then to fix this later on in life becomes very difficult. And again, I only show this because I want to show that the orbit can be involved, the upper and lower jaw are involved. Everything is really crooked this way. You see the chin is all the way over here. His smile, what we call the commissure, is higher here and lower there. And this is his radiograph, which is essentially just a Panorex showing what I just told you. So let's look at it. If that is the case and you wait, what can we do about it? Here's a patient who waited as well. And if you look at her, and we'll look at her operation. So decision was made that we'll get the ear surgery done first, and she went ahead, had that done, really no issues, and then now she sees me when she's 16, 17. You see again, the lip is higher on this side, lower on this side. You see the upper jaw. And this cant severity, I would tell you, is quite severe. When she smiles, you can get a good relationship of the upper and lower teeth, but this is the money shot. And you know, when patients when I ask them to send me a picture, they say, is the cant really bad? I tell them, get yourself a little lollipop or a popsicle stick, put it in there, and have your child close on it and send me that picture, because I can get a real good idea of this angulation. This would be a severe cant. All is not lost. We can still fix it in the teenage years. This picture is important because what I want to show you is that the normal and abnormal side. It's hard for me to see it. So if you look over here, this is, remember I said the condyle? So over here on the right side, the condyle is this portion right here. Right? This is the center of growth of the jaw. On the affected side, you see it's very small. And so this side really didn't grow in a symmetric fashion. And what happened is the angulation of the upper and lower jaw became severely canted. Here's that lateral ceph, the tracing, pretty basic radiograph. And then what we do is we take measurements. We put those x-rays and we find stable points up on the supraorbital bar, which is the top bar, stable point down in the maxilla. And then we start making measurements to try to identify how bad is the cant. Oh, let's go back. How bad is the cant? And what we end up doing is taking measurements from this point, stable point down to here, and a point down here, and we make those measurements. We get numeric values, and then we use that for surgical correction. So the diagnosis in this patient is hemifacial microsomia, a severe maxillomandibular cant, an occlusal cant, and the operation that we did was a Lefort 1, which is the upper jaw surgery to correct that cant, a BSSO, which is a bilateral sagittal split osteotomy, and a genioplasty. A genioplasty is to make sure that the chin is in the center and everything is lined up midline. So that's her pre-op over here and post-op over here. So even in patients who had a severe microtia, severe mandibular asymmetries, we're going to still fix it. And it's not, I had a family ask me, it's like, well, when my child is 16, 17 years of age, are they going to look normal? And I can tell you she's very happy, and in her profile pictures, she is essentially corrected. This is just a radiograph to give you an idea of the hardware that needs to go in. These are plates in the upper jaw with small micro screws, and then 3 screws in the mandible to help stabilize it. Those plates and screws stay in. Very rarely do I remove them. They don't set off any alarm at the airport. They don't interfere with MRIs. And these are the radiographs. And shows with the radiographs, we compare the pre-op and the post-op, and you can see that the cant has been corrected as all the lines have been leveled out. And this is her pre and post with the smiling. So it corrects the smile, it corrects the corners of the mouth, it corrects the teeth, it corrects the bite. Now, that's if you're in your teenage years and let's say you've been seeing someone else, and I get a lot of patients that have been seeing other doctors, and I see them and I go, okay, well, don't worry, we can still fix it. The real question here becomes, because most of your children here are in that age where you're looking at getting the ear done, is do I fit in that category? Do I need an operation before or after the ear? Whether it's med-poor or autologous, it really is important, whether you're valued by me or some other craniofacial surgeon, to have a good idea before you get the ear reconstruction. What is the development of the jaw? That's question number one. Do I need an operation now, or do I need an operation later? Because those are the windows to really operate on. Is 7 to 9 years, or under 4 years of age if it's severe, then in the teenage years, 10 to 14 years of age. I try to avoid operating around 4 and in the 7 to 9 because that's when they're getting either a med-poor or a cartilage, and the last thing I want to do is combine the two procedures. And I've had families tell me, well, you know, Dr. Lewin's going to do a med-poor, or this doctor's going to do an ear. Can you combine the two? And the answer is no. So you should never combine those two. They're too high risk. The vascularity, the chances of infection, it really does not make any sense. You're better off with a separate anesthesia for that. So the cases that undergo distraction, and again, this is only maybe 10 to, at most 10 to 15% of the patient population are in what we call Pierre-Robin sequence. I think we've dropped the word sequence now, and we're just calling it Pierre-Robin. Goldenhar's syndrome, Hemifacial Microsomia, and Treacher-Collins. And all of those are kind of lumped into a problem with the development of the jaw. And if it's severe enough, then this process of distraction osteogenesis is utilized. And that was, as I mentioned earlier, discovered by actually a war surgeon back in World War I when soldiers had their legs injured and were injured by mines. They would stabilize them by putting a device on to help keep the bones in place. It's an external device with some wires. And what the surgeon found out, Dr. Lizeroff noted that he would stabilize their legs and the bones would heal, but then he would find that the leg was longer than the other leg. And what he realized is if you have a broken bone and it's under tension, the bone actually grows. And based on that principle, totally by accident, distraction osteogenesis was implemented, and now we utilize it to stretch jaw bones. So we don't fracture them per se, we osteotomize them, but essentially that is cutting the jaw. And then we do a soft, gradual expansion of the bone, and what that does is it also expands the soft tissue. We get our standard pre-surgical workup. Your child would end up getting some models, some dental models, some radiographs, stents, 3D reconstruction to help us determine the surgical and post-surgical phases. This is important because I spoke to a family yesterday and they said, well, if our child needs distraction, how many operations is that? And in general, it's 3 procedures. The first one is the real operation to do the distraction, to put the device in, and I'll show it to you. And then the second procedure is to remove the arms, which is a 10 to 15-minute procedure. And then the third procedure is to remove the device completely. So essentially, you're signing up for a series of 3 procedures, the first one being the real operation to stretch it. The application of distraction is, and I do it in children that are one day of life. Really, we use it mostly in children that have obstructive sleep apnea. So those are neonates that are born with a very small jaw, not just one side. Most of the patients here, most of your kids have one side. When both sides are affected, you could have respiratory distress. And on those children, I actually do them at 1 day, 2 day of life. Once they're stable from the ICU, we do it. And that's in order to avoid this tracheostomy. And you'll see, so I'll show you some pictures where the children have been trached, children that I didn't take care of, and then they come see me so we can get the trach out. This is what it looks like. This is a standard stock, old school distractor, single vector. This is the, let's go back. This is the actual device right in here that does the distraction. You see it has 2 plates, one here and one there, what we call a proximal and distal plate. And these plates, as you are stretching, actually separate and get further and further apart. And when they're at fully separated, in other words, one plate's here and one plate's there, everything in the middle here is new bone. This is a distractor arm. This is the device that goes into the distractor and allows you to turn it, and this is a distractor key. So this goes in here, and this goes in there, And that's what allows for the process to happen. This is a baby that I've operated on. This, to give you an orientation, this is the breathing tube right in here. This is the child laying on the table. This is the lower jaw, and this is the upper jaw. Look how small this lower jaw is. And the problem with this baby is that it wasn't just one side, it was both sides of the jaws were affected. And so the jaw is really small, which pushes the tongue back, which then impedes breathing and gives you obstructive sleep apnea. So what I'm showing in here is that we make an incision right here. It's a very small incision in the neck, and then we dissect down to the mandible. This is the jaw, and we essentially osteotomize or break the jaw. This doesn't want to cooperate. We break the jaw right here, and then insert that device right here and here. Here's the two plates that I showed you on the last one, a proximal and distal plate. And then what will happen is the key, which is right here, is in position, and postoperatively, starting about day 2 and 3, we'll turn that key. And this device here and this device, which is this and this, will separate, and everything in between will become new bone. And here's this child. Let's go to the pre-op, which is right here. You see how small that jaw is? And here's the post-op there. So this is a child that, if, you know, at birth, that we immediately know that they would require distraction. That's an easy decision to make because they're in respiratory failure. When your children are a little bit older and only one portion of the jaw is affected, that becomes a little bit harder of a decision. That's why it's important to really have a good integration between the surgeon doing the ear reconstruction and the surgeon that's going to do the jaw reconstruction. So distraction osteogenesis, just some terms. We talked about this. It expands the soft tissue. It allows for de novo bone formation. There used to be external devices that were on the outside. Right now we're all doing internal devices. The device I showed you is one direction. It goes straight. There are some that are curvilinear, multiple directions, and I'll show you a picture of that. And we talked about the images that we get. I won't go over that again. And those are the phases. So we'll just kind of move forward here through some of these repetitive slides, which must have duplicated when we transferred it over. Okay, this one's important. So the device, so your child's in that 10% range, 10% population. The device goes in. Distraction osteogenesis is broken up into phases. The first phase is the latency. In other words, we put it in, we let everything be, let it heal for about a few days. Then the second phase is the active distraction phase, where we're actually stretching. And then the third phase is the fixation. We've stretched all the way, the jaw's been corrected, and now we wait and hold and let the bone form. And those are, and you'll read about this on the internet and in articles, those are the phases of distraction: latency, active distraction, and fixation. I'll skip through them. Okay, so these anomalies of the lower jaw, whether it's hemifacial microsomia with microtia, whether it's craniofacial microsomia, in other words, both sides of the jaw involved, or other syndromes, they're mostly anomalies of what we call the first and second branchial arches. That is an embryologic term for what allows the development of the lower jaw. Treacher-Collins syndrome, which I haven't seen anyone here with Treacher-Collins syndrome, most of the patients have been hemifacial microsomias, is a autosomal dominant. I'll let Dr. Sanchez talk about Treacher-Collins and hemifacial on the genetics, but it has variable expression, and it has associated clefts at what we call 6, 7, and 8, and that's the side of the mouth and along the cheekbone. And you can get conductive hearing loss in that. Those patients present with a bilateral, both sides of the jaw, symmetric dysplasia, hypoplasia of the jaw. They're missing their eyelashes on the medial aspect of the lower lid. And at the end of the day, the jaw is so small that we either distract them or we do an operation early on in life to help get them decannulated and get the tracheostomy out. So I'm going to just thumb through the clinical pictures right here. This is a child with Treacher-Collins syndrome. And you can see, let's see, does it? The eye abnormalities. The eye comes down here. There's no eyelashes in here, no eyelashes in here. This is a completely distinct entity than hemifacial microsomia or craniofacial microsomia. And the reason that it's important to know the difference is I've had families that have come with the wrong diagnosis. Treacher Collins is autosomal dominant. There are some variable penetrances, but in general, this is really a genetic problem. And I've had some families that say, well, you know, we don't want to have any more children. I said, well, make sure that you've got the right diagnosis of Treacher Collins before you make that decision. But at the end of the day, there's microtia on the right, microtia on the left. There's a cleft of the palate. This is inside the mouth. And then what happened to this child is that because of, he's obviously very unhappy here. The reason I showed is because of the tracheostomy there. And you can see the deformity is really quite severe. There's such a cant of the maxilla and the mandible. There's a trach in place. This is a child that absolutely would need a distraction. I show these radiographs because this really gives you a good understanding of the jawbone. This is his CT, and you can see the condyle. This is the growth center of the jaw. It's essentially not there. This would be a 2B in terms of the classification. Here it is on the other side. It's actually not present on this side right here. It should be right here. There's nothing there. And this is a CAT scan computer model showing what we want to create, which everything in blue is what we call the regenerate. This is the normal jaw. The normal jaw, everything in blue is a computer simulation of bone that we want to create by distraction on the right and on the left. I utilized a multi-vector semi-lunar distractor. This one's curved as opposed to straight on him. And this is it on the computer simulation showing that the device is in place and everything in blue we would anticipate to be new bone formation. This is him going to the operating room, him asleep, us getting ready to put the device in. And then it's hard to see, but here's the device that's been inserted in position. And then we get an x-ray showing the devices are there. And these are the keys over here. And this gives you a better idea. Here's the device in place. Here's the key. Here's the key. These are the keys that get turned to distract the jaw. Now, again, that's a severe case. Pretty obvious that's what needs to happen. In hemifacial microsomia, if it's bilateral, there's a high probability you'll need that operation before your ear reconstruction. If it's a 2B and it's unilateral, then there's a high probability you would need something done as well before the actual ear repair. So hemifacial microsomia, the rest of the talk is really on this. I've only got a couple minutes. It's 1 in 4,000, so that's pretty common. That's really only second to cleft lip and cleft palate. I'd like to say there's no genetic transmission. I'll let Dr. Sanchez let me know if that's still correct. I think our thought process has changed on that. This is the Omen's classification. I'll harp on it again. It really is looking at the orbit, the mandible, the ear, the severity of the nerve, and the soft tissue deficit, and a severity scale from 0 to 3. And I mentioned this, but here it is in writing. The mandible, and if your child has a type 1, mandibular asymmetry or deformity, that's very mild. That does not need an operation before your ear reconstruction. If it's a 2A, that typically does not need an operation before the ear reconstruction. The surgical intervention really happens at 2B and 3. 3, very high probability you'll need it. A 2B, I would say, it's about 50, it's a 50-50 chance. It really depends on the cant. If the cant is really severe and you're a 2B, then yes, you would get we would recommend an operation beforehand. If the cant clinically isn't so bad and you're a 2B, we wait. We wait and keep waiting until we say, okay, the cant is getting pretty bad, let's make a move. So last pictures here. This is a child with what I'd say has golden hars, which is bilateral hemifacial microsomia. You can see he doesn't have the eye abnormalities as the other patient. Definitely has the ear abnormalities and is trached, right? I didn't see him. Someone else saw him, and they said, well, because it's bilateral, he's got respiratory problems, let's put this trach in. Here's his CAT scan, which essentially shows the same thing as the last one. But the important thing is you can see that on this one, the condyles, you can see there is a condyle right there. So he would have been a 2B as well. The other one was a 3. And that's just showing the same thing, the joints in the condyle. Again, we did a computer simulation on him. Everything in blue is what we would anticipate to be regenerate. The distractor devices are placed into the computer. We verify that that's the kind of device we want. And then we go to the OR and we place it. So in terms of surgery, really you can break it down. Does my child need distraction or not? If he doesn't, then or she doesn't, you get the ear reconstructed. And then later on in life, we look at, do they need what we call a SARPE, which is a surgically assisted expansion of the palate to help correct the bite? Do they need their wisdom teeth taken out, or do they need the Lefort BSSO? And I think I finished right on time with 32 minutes if there are any questions, because they showed me the sign, hurry up. I have one question.
What percentage of kids require jaw? What percentage of kids with microtia require jaw?
So the question is, what percentage of kids with microtia require jaw surgery? Well, again, you know, you have to look at the cant and the severity. In children with hemifacial microsomia and microtia, right, the chances are high that later on in life that you will require orthodontics and some type of orthognathic surgery. If I had to put a percentage number, I would tell you it's closer to 60 to 70%. 30 to 40% can get it, can avoid it if they're mild and have an orthodontist that can help correct that asymmetry. One more, yeah, fire it up.
Can you discuss the differences between bone grafting and distraction?
Yeah, so bone graft, so distraction is de novo, and that's that slide that I showed. De novo is the ability to form new bone in situ. It's your own bone that is forming. You break the jawbone, you break the leg, you put a device in there that stretches it, and regenerate fills in there. That is bone from those cells. Bone grafting is actually taking bone from the hip, from a different site, putting it into the surgical aspect or the surgical site, and then letting it stabilize. The bone graft will actually resorb, and then your body will replace it with bone. In the mandible, in children and neonates, we don't advocate bone grafting to reposition the jaw because of the resorption, the lack of stability. Most craniofacial surgeons would go to either to distraction or wait till your child gets older and then do the orthognathic surgery, the Lefort or BSSO. Thank you.